Yep. Thank you for the chance to present here on behalf of NCCI some of the changes we've been able to go through recently. For those of you who aren't aware, just quickly, NCCI is actually 3 separate departments, but combined we're actually quite a sizable workforce, I guess. I'm employed by the ROs at Port Macquarie to concentrate on thoracic RT, which, as you may be aware, has rapidly changed probably in the last 10 years or so, primarily on the back of developing advanced technology, one of those innovations being 4-dimensional imaging to account for the effects of respiratory motion better in lung tumours. So this has really been a collaborative process across the 3 sites and really provided a platform for us to actually dramatically improve how we've treat lung cancer on the North Coast. So some of the problems of using conventional CT for lung cancer, basically there's an inability to accurately visualise the tumour with respect to the motion it undergoes, meaning 2 things. You get a distortion of the shape of the target from its true shape, but you also get no meaningful information about where the target is actually moving. So accurate target delineation or appropriate target delineation becomes quite difficult. And lastly, this lack of spatial resolution means that you're really reliant on bony surrogates when it comes to positioning the patient for treatment. So 4D CT provides us with a way of overcoming this and aligning to the target itself, and hopefully providing for more accurate treatment delivery with respect to what's been planned. So to provide you with an example of these problems, I ran into a problem myself and I couldn't actually get this movie file sent across. So if you cast your mind back to John's movie loop he showed you earlier of a 4D movie loop, otherwise you just have to suffice with 2 yellow lines which are kind of telling you what's going on. So this is a 4D phantom we have with a piston that pushes a tumour in and out, and it's also got inflatable lungs. What I did was I performed a conventional CT on this and then repeated it 3 times without changing anything, just doing the exact same scan, so they should be quite identical. But as you'll see, after each reconstruction, the shape and position of the tumour changes quite dramatically. So there's an interplay going on between the motion of the tumour and the motion of the bed as you acquire the image. So it can be somewhat of a lottery, the image that you end up with. So if you're the RO trying to put a volume on these, you can come up with quite a different answer each time, I guess, depending on what you've scanned, for what's essentially the same patient too. So I guess the reality is we hopefully expand our volumes large enough to account for all these errors, but then you run into the problem of having excessively large volumes which incorporate more healthy tissue than you otherwise might need to. So 4D CT allows us to overcome these problems by basically acquiring enough data in the scan to be able to reconstruct the tumour at different parts of the respiratory cycle. Okay, so this is a patient set up in treatment position. There's different vendors with their own solutions. We have a pressure sensor which sits on the patient's abdomen or chest in this case, and acquires a trace of the patient's breathing cycle. So as we go through and collect the scan, take the scan, that data gets time-stamped or tagged to this breathing trace. So when you're finished, if you take all the data correlating to the peak of that trace, you can basically reconstruct the patient in inhale, and conversely, if you take the data corresponding to the trough, you can reconstruct a 3D image of the patient in exhale, and you can see that we can interpolate between those and reconstruct all the different parts of the respiratory cycle. So going back to our phantom example, what we have here is a complete series of data from the one scan, showing the different phases, showing different 3D reconstructions that correlate to different parts of the respiratory cycle. So practically speaking, if you take a composite view of sorts, you can come up with a far more appropriate or target that's specific for that patient. So there's kind of a 2-way benefit going on here. For targets with amplitudes that are larger than you possibly would have expected, you don't run the risk of actually missing part of it. But conversely, for patients whose targets don't move very much at all. You've established that with use of 4D, and you can avoid the use of excessively large targets. We've done 2 studies at NCCI looking at amplitudes, and in both of those cases, the majority of patients, their targets didn't move much at all. This is a quick table looking at the first 20 patients we did, and the net effect of 4D CT for this cohort was a target size that was reduced by almost 10% from what it ordinarily would have been with conventional methods. So this, clinically speaking, this was also the patient group that had the larger target volume, so they might be more prone to side effects from treatment. So reducing the target is actually a really good thing in these cases. On the other side of the coin, we had one patient whose target moved from memory in excess of 2 centimetres. It was sitting down on the diaphragm, and if they had presented a couple of months earlier before we had 4D CT, we potentially would have been unaware that the target would have needed to be about 40% bigger than it was in order to accurately cover it throughout the cycle. So I mentioned quickly just touching on the positional accuracy. Traditionally, and I expect the vast majority of centres still do rely on bony surrogates to align the patient for treatment. This means that you're susceptible to a shift in the baseline position of that tumour with respect to these surrogates. What this picture is showing you is 2 subsequent cone beams from the same patient. They're perfectly aligned to the vertebrae, but you can see in both the exhale and inhale phases, there's a clear mismatch of the target, and that mismatch is the same. So reading into that, what we establish is that the trajectory of the tumour is actually quite stable. The mean position of the tumour within that trajectory is very stable, but with respect to the bony anatomy that we align to, it can sometimes be quite different. So 4D CT gives us a way around this by reconstructing that average position within the trajectory. And if you can use this to align to the cone beam, you can potentially reduce some of these inaccuracies. So I'm aware this is a topic that needs more than 1 slide or 2 slides, but to summarise, if you're reliant on bony method of alignment, then you can probably expect an additional 2 mils in your margin around the target to account for these inaccuracies. And that might seem small, but in some cases that's going to account to a lot of healthy tissue that's included in the treatment field. So looking at a couple of clinical situations, SABRE is obviously a technique that's had rapid uptake in the last few years, basically due to its excellent local control and survival outcomes. It's characterised by very, very high doses in very few fractions, very small margins, which makes your margins for error, consequently, that much smaller. So it's clearly a technique you don't want to be grappling with any of these issues. So I'll say that our SABRE program is somewhat reliant on the use of 4D CT. It's built on the benefit of that. So that incorporates about 15-20% of our non-small cell cases that go on to receive radical doses of RT. So just really basically, that's 30 patients in the last 2 years that didn't have to travel away from their home to a major centre, or conversely stay here and receive conventional or a lengthier dose regimen, potentially more expensive, potentially more toxic and less successful dose regimen. So for this cohort of patients, 4D has been very, very important. And for the people receiving conventional dose regimens, our department made a decision a few years back to implement IMRT and daily cone beam IGRT to complement those benefits we saw with 4D CT. The rationale for that was basically to reduce OAR doses, in particular the lung. And in reviewing the first 30 patients we did with this, I'll just give you a quick comparison. I think we've already seen it once. David Palmer did a recent review of some 840 odd patients across 3 continents. I think it's the largest of its kind. And he found that 30% of those patients developed grade 2 and above symptomatic radiation pneumonitis, and it was actually fatal in 16 of those cases. So, trying to get it there. We obviously developed a protocol that lowered lung doses along the lines of a LAR, rather than just aim for a dose threshold. And what we have found in those 30 patients was we got no grade 3 toxicity at all, and we only found one case of grade 2 radiation pneumonitis. So this is obviously a small cohort of in some sense, and it does incorporate a degree of hyperfractionated non-chemo patients as well, so take that into account. But they're very good results, and obviously IMRT plays a large part in that, but as does 4D CT, its role is quite integral as well. Once again, we found the majority of these patients had a very small amplitude, which meant that their volumes were subsequently smaller than they otherwise would have been, which would logically flow onto these results as well. So that's all I have to say. I'll thank you. And is that me? I don't remember putting that slide in.
Questions or lunch? There's 2 questions. Can I see if there's any questions from the audience?
Yeah, thanks for a great talk. I'm wondering what you think about 4D cone beam. Is that something we all
Yeah, I was going to talk about that, but just the time restrictions, I guess. It's very important. It's more important for Sabre, I feel, given the margin for error is that much smaller. Our protocol probably falls down for the conventional guys when an amplitude is exceeded, and that's the cases that we would use 4D cone beam to ensure accurate alignment. But even still, for those larger cases, I think we're probably landing on 4D cone beam being less important for conventional and just solely for Sabre. All Sabre cases, I would have thought too. Yeah, that's right.
Any other questions at this stage? Right. Well, thank you very much for your presentation.